Hello, and thank you for joining me again today on the Finding Hope After Loss podcast. If you've ever been told that everything with your testing looks normal, but you're still not getting pregnant, then this episode is one that you want to hear. Today, I'm joined by Dr. Grace Charles, a naturopathic fertility doctor who helps women uncover the root cause of infertility before they jump straight to IVF. We're talking about unexplained infertility, what's often missed in standard testing, and how to get real answers when you feel stuck in that space between basic OB care and fertility treatment. Be sure to stay tuned until the end because Dr. Charles shares what should be explored before accepting an unexplained diagnosis and what questions can change the direction of your care. Hello, everyone. Today I am here with Dr. Grace Charles. Do you mind telling us a little about yourself and your background?
Of course, I'm a naturopathic physician and I'm a root cause fertility doctor. What I do is I help women and couples figure out why they haven't gotten pregnant naturally or stayed pregnant before they go ahead and invest in IVF. I work with a lot of women who are being told by their gynecologist and their reproductive endocrinologist that IVF is really their only option. And they have a diagnosis of unexplained infertility or unexplained recurrent pregnancy loss. And they're really just not comfortable making that leap to a very expensive, very invasive treatment before they better understand why they ended up in that office in the first place. So my goal, my deliverable, is to explain their unexplained pregnancy loss or their unexplained infertility.
What kind of got you in that line of work or with that particular interest?
I saw a gap in conventional care. I love helping families grow, and it turned out I was willing to dig in and do the work and really like solve the puzzle. And that appealed to me. I love the idea that by doing this work, we're making healthier children, we're putting healthier babies in the world. But I don't have a personal story of loss or infertility. It's not a very compelling story. I saw the need. I was doing a lot of women's health, and women that I was working with were trying to get pregnant, and I was seeing the model that they were going through and the algorithm they were going through, and I saw some gaps there. So it's been really fun to try to seal them up.
I definitely agree with you there. I feel like with a lot of infertility clinics and IVF clinics, their job is just get you pregnant. And they don't
Yeah.
really take the time to figure out, okay, but why are you not? Or, they just like, let's jump to the next cycle.
Right. They have a tool that works, that sometimes works. I mean, it's good enough. And reproductive endocrinologists are incredible physicians, and they are using this. I mean, IVF is a really incredible tool, but that's kind of the only. If you're being referred to a fertility clinic and meeting with a reproductive endocrinologist, there are only a true handful in the country that aren't going to say, "Let's try IVF." And that's a big try if, again, we just don't know why we're there in the first place.
So if you're like seeing someone who is having trouble finding out why they're not getting pregnant, is there a place that you typically start or what is your process?
My process is to learn more about their health history, to talk about things other than their cycle. Of course, I want to hear about how their cycles are presenting, but I'd also like to know how they're sleeping, how they're eating, if they're exercising, what their stress management techniques are. And I also want to know a whole lot about their male partner's health. And I think that's something that's vastly overlooked in this process is getting details about male health. I'm not sure when fertility became a female issue, but it's quite literally 50-50 here. And without good data on both parties, it's hard to make a good diagnosis. It's hard to deliver that this is why you're not getting pregnant. So full workup, laboratory workup, imaging workup for both parties is how I start.
Yeah, I feel like a lot of people, like you said, that infertility is all about the woman when
Yeah.
it's like, okay, but like you said, they're 50% of the DNA. Why are we
They're
not?
50% of the DNA. And in one third of my cases, I'm really transitioning. I mean, I market to women. Women are the ones that find me, call me, set up the free call. But we gotta rope him in. And in that second visit, when I've ordered the labs, I've gone through them, I'm talking to both parties. Both parties have to be at that second visit because in one of three times, I'm turning to the man and saying, "You're subfertile, you're infertile." We need to work with your health. And sure, there are things we can do to continue to improve the female's health, and we do those things. But from my clinical perspective, you're the main contributor here, and this is where we need to start. So it's wild to me that men get away with one semen analysis. They find like one sperm on there that looks good, and they're like, yeah, it's probably fine.
Like, like
We need more
okay.
information than that.
Yeah. Do you find that, I mean, obviously, I know women are willing to put a lot of work into becoming pregnant. Do you find that the men will put in the work, or do you think there's some resistance there?
I find that once they understand their stake in the game, their involvement, they are mostly willing to put in the work. I have a few men who drag their feet, and I I have to have a pretty straightforward talk of like, we can't do this. You're asking. I had just sent an email out last week, and I think the analogy I used was like, we're asking a race car driver to drive blind. If I can't do a lab test on this person. And semen analysis, I don't have a lot. Clinically, I'm getting less and less patient with men who aren't willing to do a semen analysis. You can do it at home. You're ejaculating. I'm sorry it was an uncomfortable orgasm for you, but I mean, a current like typical workup of a female infertility is the hysterosalpingogram. I mean, that's speculum, catheter through the cervix, dye being pushed into the uterus. This is a painful procedure. You bleed afterward. I'm becoming less and less patient with men who are like dragging their feet on getting a blood draw and a semen analysis because that's what we need. We need a thorough blood draw, a thorough workup, serum workup, and a really high quality semen analysis, and we can learn quite a lot.
I know it does seem like they're being big babies. I'm like, because I've had that test you're talking about, and yeah, that was not fun. And
Yeah,
yeah, it's so invasive for the women and so many blood draws and so many, if you have to do IVF or so many shots and so many, and they literally have like one, maybe two things they need to do. It's like, come on.
right. And it's frankly it's not enough. There's another gap in care there, and I think that I hope that in looping them in and bringing them into that visit and really explaining that to them of you are half of this picture, whether or not like, okay, great, maybe we do have a normal semen analysis. What about your blood tests? I mean, men with diabetes, men with hypertension, these are conditions that we know cause greater miscarriage risk.
Mhm.
So I think especially in recurrent loss, we see the workup of the female.
Mhm.
Conventionally, if there is recurrent loss, a workup of the man is not included.
Right.
Like once the pregnancy is in, so to speak, he's out of the picture. But that shouldn't be the case because his DNA is half of it here.
Yeah, that is, again, it's like putting all the blame on the woman. Like it's her fault. Like, well, he did his part, but your
Right.
body just
Yes.
can't do it, you
It's
know?
wild. Just this burden.
So
I
what do you
become more
think
and
of?
more a feminist as I have
I
my clinical
know.
journey.
I mean, yeah, I can see why though. Yeah, so for people who are, dealing with miscarriage and recurrent miscarriage, do you agree with the having to wait three miscarriages before any testing is done, or do you think it should be done sooner or done for everyone? How do you?
Well, the ACOG recommendations are now two, with two or more. So you could make the case at two to a very conventional. You can say, nope, these are the guidelines. But I work with mostly type A women who are very used to getting what they want. And if they prepared for this thing and they didn't get this thing, they're not going to try again without more information. They're like one is enough for them to say, work me up. And I've learned to trust women's intuition. And these are tests that are not harmful to know the information. It's not going to give us information that we don't know what to do with or that puts us in a clinically sticky spot. It will either give us a reason or it won't. It'll either say, yeah, there's APL here, or oh, yeah, whatever it is, APS rather. So these are tests that I know what to do with clinically. And if they want to do them before having to lose another pregnancy, I'm happy to do it after one.
Are there like common things that you find that a lot of people have that aren't typically tested for? Like I know a lot of people have, PCOS and endometriosis. I know blood clotting disorders are one that isn't always tested for. Are there other things like that that you've found are common?
Yeah, you've hit the big ones, but I would say the most common one I find is Hashimoto's thyroiditis, so autoimmune diseases that are sort of hidden or overlooked. Thyroid disease is something that we usually, if someone's not getting pregnant or not staying pregnant, we usually run a TSH conventionally. That's a lab marker that tells it's what the pituitary is telling the thyroid to do. And if that's over a certain threshold, we say, oh, you have hypothyroid. Let's get you on some thyroid medication. And now maybe you'll be able to get pregnant or maybe you'll be able to stay pregnant. But if we run more tests on the thyroid, and most women in America who are diagnosed with hypothyroid, their thyroid's underfunctioning, have something called Hashimoto's thyroiditis. They have an autoimmune thyroid disease. It's more likely that you do have that than don't if you have this diagnosis of hypothyroid. Conventional medicine doesn't treat it any differently than they do hypothyroidism, and that's why they don't test for antibodies, thyroid antibodies, because it doesn't change the way they treat. But it's very helpful to know because there are thyroid receptors on the endometrium, there are thyroid receptors in the ovaries. And if there's autoimmunity, if the immune system is attacking at the thyroid receptor sites, well, there's going to be immune activity in the uterus where that zygote is trying to implant. So there are implantation issues there. So that's a very common condition I see that just doesn't get tested for. And it's pretty easy. I mean, out of pocket, these are $22 tests.
Oh, wow.
Yeah, I mean, through insurance,
Yeah,
that's a
yeah.
whole racket, and it inflates the price somehow, and you're like, oh, I have a $400 bill. But through an out-of-pocket, like just self-order, these thyroid antibody tests aren't very expensive, and they can really crack open the case that just isn't considered in conventional medicine. Again, because they don't have the tools to treat it. They're going to look for something like antiphospholipid antibodies, because if that's the reason, that's another autoimmune disorder where the immune system is attacking a part of the cell, and that particular place in the cell leads to blood clots. Conception, growing a fetus, it requires a lot of new blood flow. So blood clots are a really big problem. That diagnosis, if we find it, is pretty straightforward to treat. The female gets a shot of blood thinners, essentially, for the pregnancy. And problem solved. We now have a full-term pregnancy. So that one is actually like most doctors kind of love testing for APS because they can treat it. It's like, ta-da, okay, done. But there are other blood clotting disorders that are a little trickier to treat that sometimes don't get tested for in that panel. But I would say PCOS, endometriosis, but other diagnoses too. Diabetes, obesity, luteal phase problems. So there are other things we can just look for and treat.
So it seems like there's a lot of common things out there, but there's also less common things that you probably come across as well.
Yes, and that's why being a functional provider, so kind of walking the line between a conventional, I want to make sure all the conventional workup is done, of course. That would be silly not to. But we also can go a little deeper and look for these functional conditions that aren't quite a disease state, but we know that diagnosing and treating them make people feel better and like improve their fertility results.
See, I had no idea about the thyroid and the receptors being in the uterus, or I just like I
Mhm.
had no idea that because I always wondered like how would having
Right.
a
Why is a
thyroid,
thyroid problem?
yeah, affect fertility, but that makes complete sense, and obviously stuff that we're not taught about our bodies and our cycles, and yeah, we just wouldn't even know to look for these things.
Right. And some of these things are just missed in the typical screening.
Sometimes I feel like the screenings were made for men and not for women.
Screenings certainly were made for men. Like we're just kind of getting in on research here of separating out like, oh, was this study even, did this cohort even include women? Should we apply this to women's health? I mean, that's a huge understanding. Like that's a big breakthrough in medicine right now of going back into the literature that we're basing all of these treatment plans on and saying, wait a minute, were women even included in the study? So
Which is
how are we
crazy.
making the jump and applying this to women's health? Yeah, it's wild.
Which is why I'm glad there's people like you out there who care enough about women's health to dig deeper and do things like this,
Hmm.
because not all doctors will.
That's right. Because they're doing other things. They're meeting their quotas that are set by insurance company. I mean, there's all sorts of reasons why doctors do what they do. Ultimately, like we're all trained in medical school. Everyone's doing their best. And especially gynecologists. I mean, these are surgeons. They're taking care of children as young as 8 years old, getting their first period, women who are go like postmenopausal and having symptoms and everything in between. It's not on them to become fertility experts. They go through the standard protocol. And if it doesn't quite make clinical sense to them, the appropriate thing to do is refer to the reproductive endocrinologist, who is, as we said, going to recommend IVF. So there's this big gray zone in the middle of like, what else can we do to learn about our fertility, to improve our fertility, and really to rope the men into this conversation.
Yeah, yeah. So I know that age is often a big factor in fertility. Is
Mhm.
that, I mean, and I know you've talked about this a little bit about diet and exercise, but what are some other things you see like that aren't just about the age?
Big issues that I see clinically, hidden autoimmune disease like Hashimoto's and others that we have to dig for. I would say toxins, toxicants in the environment that are getting into our bodies are a really big one. We see that more classically when we study male fertility. The semen analysis is just so easy to retrieve because it's not invasive that we can really track how something is affecting male fertility. But I think it reflects on female fertility just as well. But with the data is on male fertility. So things like parabens or phthalates, BPAs, so chemicals in our environment that were exciting when they were invented and made our lives much easier and made our lives smell better and made our food fresher. Unfortunately, now we're learning are endocrine disrupting chemicals. So they're getting in the way of hormone signaling and they're worsening our fertility. And that's very clear. Phthalate exposure will decrease the amount of sperm that a man makes. When we compare semen analysis today to semen analysis 50 years ago, we see a general decline of fertility. We, by and large, blame that on environmental chemicals. There was a good study done in the 90s comparing head to head men who ate organic and men who didn't focus on eating organic, twice as many sperm in men who ate organic. So we know these chemicals are interrupting fertility, disrupting fertility, worsening fertility. So that's usually a big conversation I have to have with patients about getting the scents out of the house, stop microwaving in plastic, get rid of the nonstick pans. And by and large, if you do those three things, you have a big change. I mean, your load of those chemicals really goes down, and we see improvements in fertility just with those three things. There are all sorts of like if you break into it, it gets very overwhelming of like, what do I do that's not toxic? No, I need a bubble. But if you can just find the bigger things in your lifestyle and your home and remove those, it does have really big impact. So that's kind of a fun one to work with because it feels overwhelming of like, well, it's the environment, it's not me. But a couple of quick changes in your household can make a big difference.
See, that's encouraging to hear because those three things are easy. I mean,
Yeah,
easy enough to
easy
do, but
enough, right?
I mean, yeah, they require some changes in your life. But,
Sure.
like you said, it gets scary when you read about it online and you're like, well, I can't use anything that I'm using. So
Right.
then you do
Everything is
nothing because you're
toxic. So what's the
overwhelmed.
point? Yes, but we've identified three biggies, and the main ways that they're getting into our lives are those three things: the scents and the nonstick pans and heating plastics.
I used to be one of those people that wanted a scent in everything. I was like, because I love how
Yeah.
everything smells. And now I'm like, okay, now I've been trying to phase that stuff out. And now sometimes I'm like, oh, those scents are overpowering now.
Right? When you do, like, yes, once you've gotten away from them and then you smell them again. I happen to live with three boys. I have two sons and a husband, and the house stinks. So I'm always looking for a natural way to to improve the scent. I get it. We want to walk into our home and for it to smell good. And there are ways to do that that don't contain endocrine disrupting chemicals that are actively worsening our fertility and our children's health.
Yeah. I mean, that's another thing. I have a son and I have two daughters. And so a lot of times I think, how are things like this? I have
Mhm.
PCOS. So I know, what it's like to deal with that. And so I worry all the time about how things are affecting my daughters because, I'm like, are they going to grow up and go through the same thing? And
Right. And what you're talking about is called epigenetics. How we know that they've been handed the genes they've been handed. That's the gift of the family tree. But how can we make different genes express, not genes, how can we make different DNA express? How can we change how, if they are going to develop into PCOS or not? And it turns out there is malleability here. We can have an impact by the way the lifestyle changes. How are they eating? Are they exercising? How are they managing their stress? Are they getting high quality sleep? Those are like the four pillars of, are we setting our kids up for more or less health as adults? And the same thing is true of our fertility. Can we get those things regulated before even getting pregnant? Then we can change everything.
And it's funny because when you talk about it, it sounds so easy, but yet
Oh,
it's something that so many of us struggle with, you know? Like it's
sure.
like
Well,
the basic things.
it's not easy, and especially when you're a mom. It's not easy to get like even one of those four things down. It's hard. And the things that make it easy are the things we're supposed to avoid. So
Right.
it's not easy, but it can be broken down into bite-sized pieces. And I think everyone can feel more empowered about making change if they understand the reason they should do it and the some depth behind it.
So, what about the diagnosis of unexplained infertility? How do you feel about that in general?
It's not good enough. It's not good enough. And there have been a very small handful of cases where that was the best I could do too. But I would say for 95% of my cases, my true deliverable for like the first step of my system is is getting that diagnosis, pointing you to a page and saying, this is why you're not getting pregnant. This is why you're not staying pregnant. Because I truly believe that there's an answer out there. And as a clinician, as a puzzle enthusiast, as someone who wants to know more, also type A, I'm just not going to stop until I get there. But there are places to look, and there's the stuff we've already talked about, looking for endometriosis, looking for hidden autoimmunity. Gut health is a big one that's vastly overlooked conventionally. Your colon sits right next to your ovaries. And if there's inflammation in the colon, you bet that we're not going to have an anti-inflammatory environment in the pelvis. It's just not possible. So we ask more questions. I ask about daily bowel movements, gas, all the things that just wouldn't necessarily be discussed in a conventional medical setting, and running some stool tests and finding like, oh, well, there's a bacterial overgrowth here. Let's treat it. Let's get your gut back to how it should be. What's optimal. It's wild what people think is optimal. Vaginal microbiome. This is another interesting piece of, if there are bacteria, overgrowth of certain bacteria in the vagina, it turns out we're putting people more at risk, especially for recurrent loss and early miscarriage. There's a test on the market. I've no stake in the game here. It's called EVVY, EVVY. It's a self-order at-home vaginal microbiome test. You pay $250. They send you a kit. You do a vaginal swab. You send it back, and they tell you about everything that's growing in there. And really, there should just be only like a small handful of bacteria. Most of it should be one single strain. And the reports I get back, because I have all my patients do this one now that I've learned about it and seen such great results with treating, is that there are certain patterns of microbial imbalance that are lumped in with, maybe predictive of certain fertility outcomes, and treating the vagina helps everything.
Hmm, that is super interesting.
It's so interesting. So there are other places to look. So the bottom line is, unexplained infertility is explainable if you're willing to dig deep.
Yeah, this is so interesting to learn about all this. I've heard so much lately about, gut health and its importance to so many different things, and yet it's something that, again, we're never really taught about to look there for anything.
Right. It's a big piece of the puzzle.
Is that something that's important for men as well, then, for male fertility?
Absolutely. Making sure that they're eliminating properly, that they're not super gassy, that they're not complaining of tummy aches all the time. It's Health is critical for both parties, and looking for any reason. The semen analysis is so handy because it tells us, if there were an analog to a semen analysis for women, I mean, my job would be a lot easier. We have to make a lot of jumps with the information we can gather about female fertility because it's so protected in those ovaries. But males, they just put it all out there, and the semen analysis tells us so much. So we really can say, like, if there's something out of order in the semen analysis, then we have to go digging as to why. If the sperm don't look like they're supposed to look, Well, why? Why not? Where is this inflammation coming from? Probably the gut. It's one of the bigger ones. Diet and gut are the drivers of a lot of inflammation and unexplained inflammation in the body. So yes, we look there for men too.
Yeah, see, this was not stuff that I learned when I learned about having PCOS. I was basically diagnosed at 16 and told, okay, come back when you want to get pregnant. You may have trouble getting pregnant. Nothing about increased disease risk, nothing about, metabolism, nothing about cortisol, nothing about anything.
Right.
It's crazy.
Yeah. Yeah. As someone with PCOS, you have a higher risk of Hashimoto's thyroiditis. You have a higher risk of miscarriage. You have a higher risk of insulin resistance. And there are things to do about it, but that is the conventional approach. Go on birth control until you want to start having babies. And then like cross your fingers that it's easy enough, or really kind of just shuttle you into a program of like, oh, you're not ovulating because you have PCOS. Let's just let's just give you a medication that helps you ovulate. Again, an incredible medication that has helped so many women get babies in their arms. But I wonder if we had taught them about PCOS when they were given that diagnosis at 16, if they would have needed it.
And I often have that same thought because we did go through some fertility treatment with Femara, with Clomid, with
Yeah,
injectable medications, and I'm like, if I had known about these diet changes, that I was doing the wrong kind of exercise, that all of
right.
these things, I do often wonder that would I have had the same problems?
Because I'll tell you what, pre-kids, you probably would have had the lifestyle space to make those changes. You said like, you make it sound so easy. Those four things are really hard. Definitely as a mom, those things are really hard. But when I talk to women who are trying to get pregnant, who want to become moms, they actually often have a little bit of spare time. I think back to like before I became a mom, what did I do with all that extra
Yeah,
time?
I know.
So it's there. I know it's there, and I know I can find it for them. So when we find those pockets of time, we can put the work in to improve the way we're handling stress, our quality of sleep, how we're eating, how we're moving, and those lifestyle changes can really turn PCOS not around, but can shift things so that we're moving in the right direction.
Yeah, no, I definitely agree. Being a mom, you have very little time to do
God.
things. It's like you want me to sleep? What does that mean? Well, are there any other things that you want to add about, I mean, anything really, any other advice you want to give or, for people who are struggling with this?
Sure. I think my advice would be push for a thorough workup. And if your conventional gynecologist or primary care doctor doesn't want to run it, we shouldn't have to be our own doctors. But right now, we're in this age of information where we probably could be our own diagnosticians if we put a little bit of research into it. So there are so many resources out there that will help you narrow down the list of really what you should be testing for. So at least you can, or just hook up with a functional medical doctor. You don't have to be your own doctor, and say, I want a really thorough workup of my health. Haven't been able to get pregnant. I haven't been able to stay pregnant. And you know what? My husband's here too, and he wants that too. Drag him in. I would say, yeah, just push for more testing because there are answers to almost every case.
Kind of an offshoot of that. I mean, I know we've mainly been talking about, people who are trying to get pregnant, but do you find that finding out this type of information is important for women who are not trying to get pregnant or who are, going through menopause or who are just done with their pregnancy years or those other women?
Absolutely. I mean, this is women's healthcare, and this is how we should be working somebody up who's feeling unwell. Sometimes their only symptom is I'm not getting pregnant, and that's where they intersect with me. But a lot of times, I mean, when I work more generally with women's health, the symptom was I'm tired. I'm not trying to have babies anymore, but I'm tired, and that's nobody will tell me why. And I've been offered antidepressants and been told that's just getting old. So I think there's always a reason to empower yourself with more information about your health and improving, especially in those four pillars, those four core areas. But yes, this could apply to anyone. My favorite, I shouldn't say favorite, and a really exciting group of people to work with is women who haven't even started trying. They don't know if they're going to have fertility problems or not. They just want to optimize their health before baby comes, before baby is even made. And I think that's such incredible foresight to say, I know that to make the healthiest baby out there, I got to get myself a little bit healthier first. And they are a fun group just because they're so motivated to put in the work.
And they have the time.
And they have the time. They'll find out. They'll learn.
Yeah. So if people were wanting to work with you, where would they go to learn more about that?
Please, please grab my 10 things to do if you're trying to get pregnant list, because that's things you can do to improve your fertility today. Right now, they are bite size, but move the needle, certainly. That's Dr. Grace Charles, drgracecharles.com/today. And that's going to get you kind of into my circuit. Grab that list, and that'd be a great way to connect with me too.
Do you see people only in certain states, or can you see from any state?
There are a little bit of regulations around naturopathic medicine. I have licenses in Colorado and Utah. That's really where I focus, but there are 17 other states that don't regulate naturopathic medicine. So I am able to work with patients in those states more as a consultant and coach, but effectively doing the same exact thing. So there's a list in the facts question section of my website if you want to learn if you're in a state that I can work with.
There's always that red tape you have to deal
I
with,
know,
right?
I know.
Like, yeah,
So
I just
true.
want to help people. I don't want to deal with all of this. Well, thank you so much for coming on today and sharing everything with us. I definitely learned a lot.
Oh, this was such a fun chat. Thank you so much.
Thank you so much, Dr. Charles, for all of this amazing information you shared with us. Before you go, here are a few takeaways that I want you to think about. If you've been told your infertility is unexplained, it doesn't mean there's nothing left to look at. It just means that there's more information still to uncover. Write down your questions, advocate for testing on both partners, and don't be afraid to seek a second opinion if something doesn't feel right. Take this episode as permission to slow down, gather all the information, and make decisions from a place of clarity instead of a place of pressure. If this conversation helped you feel less alone, share it with someone who might need it too, or leave a review for the podcast on Apple or Spotify. Also, make sure you're subscribed so you don't miss what's coming next. Thank you so much for tuning in, and remember, we are all in this together.